For chest trauma, the questions will be assessment and interventions. What are the questions? Assessment and intervention. So you expected to find what does it look like? What signs and symptoms will the patient manifest? And then what are your corresponding actions? Stick to that. Of course, with any chest trauma, we're talking about pneumothorax and hemothorax. What is the treatment? Okay, and we already did chest tubes. Okay. Please please look at it overall, because based on our thoracic anatomy, is it possible to only have one all the time? No. So let's say the deeper the injury, that means how did it get there? Does that mean, so let's say this is trauma, right? So therefore, for trauma to cause lung contusion, that means what must have happened as well? A contusion is there's bruising or laceration on the lung. How did it do that? There must be other injuries, correct? I mean, the lungs and the heart are very protective. We have a hard rib cage, we have muscles, we have fascia, we have fat, we have skin. So there's several protections before the lung. So that means if you injure that, you must have sustained multiple trauma. All right. So again, chest trauma, is it always one? No. There you're dealing with multiple. Are we clear? All right. So I were you, create a table for each one. Not blunt trauma, this is not really specific. Let's go to the next one. Here, rib fractures would be the first one. Now, there's a difference between rib fractures and let's look at this one. So a rib fracture is when a rib is, you can have multiple ribs involved, but then if it's only broken in one place, that's called a fracture. Okay, because are the rib cages only attached to the sternum? No, it's also attached to the spine, right? So you have two connections for the ribs. So each rib is connected anteriorly to the sternum and posteriorly to the spine. If you broke it only in one spot, we call it a fracture, which not always causes respiratory problems. Although if it's displaced, it can puncture the lung and cause a pneumothorax or a hemothorax or whatever. Okay, so it punctures the pleura, so that will cause air or fluid or blood to accumulate there. However, the chest will expand because it's still going to be, as the lungs inflate, so because they're still attached, even if it's broken in one spot, it will move. So there's ventilation. However, if it's broken in two places, meaning one single lung, this lung, rib. If a rib is broken in two or more places, is there a floating segment now?
Yeah.
Yes, because this part here is attached to the sternum, this part is attached to the spine. What is this part attached to? Nothing, just to the muscle. You know, you've eaten baby back ribs, right? So try breaking that baby back rib in two places. So that section that's not attached in the middle is a floating segment. That's a different story. That can now compromise breathing. So because what will happen? So this is a flail chest, right? So therefore, if nothing is holding that independent segment, that floating segment, yes, the remaining ribs that are still attached will move. However, as the lung expands, since nothing's holding that floating segment except the muscle, the really juicy, nice muscle, right, on the rib, so it will suck in. So there will be a paradoxical movement. So when you inhale, what's supposed to happen? Right here, right? Lungs are supposed to expand and collapse during ventilation, right? This is what's supposed to be your movement. This time, there will be paradoxical movement. When you inhale, this section it's gonna sink in. And when it does that, look at what it's doing to the mediastinum. It's moving your heart away from the mediastinum. It's compressing the large vessels. Look at the superior and the inferior vena cava. Are they still in place? They're being squeezed. Okay, so when you have a flail chest, this will not only have respiratory problems, but cardiovascular. Patient will go into, what type of shock is this? Obstructive shock. Remember, cardiogenic is a coronary vessel problem. This is not a coronary vessel. This is a large vessel problem. Okay, so this will be obstructive shock. So you're compressing the large vessels. Okay, so there will be paradoxical movement on the affected side. However, it will push all the structures to the opposite side, including the heart, unfortunately. So that's the difference between a rib fracture and a flail chest. So which one is an emergency? This is an emergency, because this will lead to shock. So there's the description of the flail chest. Again, focus on creating the table, look at your manifestations. Some of them, nurses really don't have much role except to call. Okay? Some interventions will tell you, call rapid response, okay, because it's an emergency, especially a flail chest. Or you can do, give oxygen. That's the best you could do under our scope of practice. But expect to give opioids because these are painful, correct? Yeah, so especially trauma. So you have flail chest or rib fracture, it's painful to breathe. So give pain medications. Usually we use opioids. If they need a chest tube, which obviously involves a pneumothorax or a hemothorax, then the chest tube. What's your intervention for a tension pneumothorax? Okay, let's do tension pneumothorax. Before I forget, okay, this is contusion, meaning this is injury to the lung, a bruising, laceration to the lung. Okay. So tension pneumothorax. So this is also an emergency. So this is a more progressive form of pneumothorax. And pneumothorax, if it's stable, you probably have a minimum 5 ml of air or more. But a tension pneumothorax is one wherein the cause is nonstop, meaning it's a quickly evolving process. So let's say I sustained a gunshot wound. So a hole was created through my skin, through the muscle, and then ended up in the lung. So it went through several structures, correct? Now, because there's a hole in my lung, and let's say it doesn't have to be a bullet, it could be an ice pick. So I created a hole, but then on its way out, because there are several layers, can it close the wound? Meaning, I have a lung, I have a pleura, I have fascia, I have muscle, I have fat, I have dermis, and then epidermis. Are all those layers in one spot, or are they constantly moving? Let's say I got stabbed while I was doing this. So I got somebody was stabbing me, right? First I got it, but then he had a second ice pick on the other side. So when I did this, I raised my arm. So I got stabbed while I was in this position. And then I did this. So did the track created by the ice pick remain aligned?
No.
No, because I have to put it like this to realign it, right? But now I'm so now there's a hole there, but then will it continue to be aligned? No. However, the hole in the lung, is it still there?
Yes.
Will it continue to leak air as I'm breathing? Yeah, every breath I take, air will escape into the pleura, nowhere to go. Here, that air is trapped. I can't stop breathing. I have to breathe. So will this scenario stay the same? Will the air there stay the same amount? It will only get worse. So minute by minute, I'm leaking air into the pleura. What's going to happen to me? I'm going to die. This lung will collapse. So I need, what's the intervention? So this is the same as, remember flail chest? Same effect. It will have a mediastinal shift because the air is accumulating so much on this side, collapsing this lung, but the pressure builds up. I lose negative pressure. It's pushing everything toward the opposite side. So the only way is look at this. This is all air. Okay, all of this is air. This is what my lung is doing now. Look at the size of the lung. It's supposed to be this big. Now it's only this big because it's occupied by all this positive pressure. Because air always rises. So where will we intervene? Where will the doctor insert a tube? Okay, so let's look at the terms first. So under intervention, where will it be inserted? The second intercostal space. Why there? I was stabbed down here. Why did you put the chest tube up here? Okay, the air will always go up. In the emergency though, because we don't have the chest tube, the doctor can put in a large needle into the same spot just to release the air, and then the lung will re-expand, and then we'll follow it with the chest tube afterwards. Okay, but the initial will be the needle. Okay. Yeah, you've seen it in movies. They use a straw or a pen, whatever. Yeah, you've seen it in movies, right? So it's basically anything you can, any cylindrical object. Okay, the whatever you have. Right here. So in an emergency, you have tension pneumothorax. The patient needs at least a 14 gauge or bigger needle. So the doctor will do this first. Can be done in a few seconds, and then the chest tube will follow. Okay, once we're in, when we have the equipment or we're in the hospital already. But in the field, so this is what we need to do. So this will re-expand the lung quickly and get rid of the air. So the life-threatening episode is controlled, and we already did chest tubes, and that's it for respiratory.